Good evening, everyone. So thank you for joining me again today. So today, in this lecture, uh, I wanted to talk about stress echocardiography. But before we go into stress echocardiography, I wanted to just talk a little bit about identifying the left and right ventricular wall, their coronary distribution, uh, and how to remember those areas. I hope I could give you some tips because it is quite difficult for me to identify which wall represent which coronary artery segment and how to name it. So let me give you to begin with some tips to remember the wall of the left ventricle. Okay. So number two, when you look at the view in echocardiogram, you can see all the walls in two combination. Okay. Now the first one, if you look at apical 4, apical 3, and apical 2 chamber view, then you will see all walls of the left ventricle. Okay, apical 4, apical 3, and apical 2. So the other one is if you go for short axis, if you look at short axis base, mid, and apex, you can see all segment of ventricle walls. So ventricle walls consist of 16 segment plus what we call one apical cap. So overall there are 17 segment, but the apical cap does not contract. So we have 16 segment that is contracting, and we need to know how to name each of the segment. So I just give you a tip. The way to remember, I think number one is all the wall that you see in the left ventricle, you divide them into base, mid, and apex. So look at what they are. They always will be either base, mid, or apex. So another tip is whenever you see right ventricle at the side of the left ventricle, so the wall that that is dividing the left ventricle and right ventricle is the septal wall. Okay, if you see the right ventricle at the side, so the wall that you are seeing is the septal wall. So what do I mean by that? Okay, so illustrate by this picture here. So you can see the three image here: 4 chamber, 2 chamber, and 3 chamber long axis view. So if you look at all this, you will see all the 17 segment of the left ventricular wall. Okay, same goes for the bottom one. If you see all three, you see all the 17 segment of the left ventricle wall. Okay, how do we name this segment? So one of the tips is to divide into base, mid, and apical. If you see all the wall is either base, mid, or apical. Whenever you see a right ventricle at the side like this, the wall that is opposite to that right ventricle is the septal wall. Okay, same goes here. This is the right ventricle here. So this wall is a septal wall. This is a septal wall. This is a septal wall. Okay, so that is the two tips. Now the rest you have to remember and you have to put it in the memory. Okay, I give you an example. This is basal infroseptal. Okay, basal infroseptal. This is mid infroseptal. This is apical septal. What about this? This is at the bottom. So this is basal anterolateral. This is mid anterolateral. This is apicolateral. What about this one? This is 2 chamber view. Okay, there is no septal because there is no right ventricle. So this is basal inferior wall. That is basal anterior, mid inferior, mid anterior, apical inferior, and apical anterior wall. All right. Now, what about this? You can see the right ventricle here. So this must be septal. So this is basal anteroseptal. This is at the bottom. This is basal infrolateral, mid anteroseptal, mid infrolateral, apical septal, apical lateral, and on the bottom here and the top here is the apical cap. Okay, so that's how you remember the wall of the left ventricle. Okay, and another thing that I wanted to show you is you can also do this at the bottom part. Okay, I prefer looking at the apical 4, 2, and long axis view to determine which regional wall distribution. But some people might prefer the bottom one. Okay, so we use both. So, but some people might feel that the top one is better for them to think, or some people might think that the bottom one is the better one. Okay, if the bottom one, you can see that this is the This is the right ventricle, so this is septal. In transthoracic echocardiogram, this is anterior and this is inferior. Okay, for example, that is basal anterior, that is basal inferior. This is septal, so this is basal inferoseptal. This is septal, this is basal anteroseptal. So if you go to this side, okay, when you see papillary muscle, this is a mid segment, okay. So this is mid anterior, mid inferior, mid inferoseptal, mid inferolateral, mid anteroseptal, mid anterolateral. Okay, what about this one? Apical inferior, apical anterior, apical septal, and apical lateral. So that's how you name all the walls. Okay, so that is in terms of the naming of the wall. What about the coronary distribution of the wall? So the coronary distribution is a little bit more complicated than that, okay? But the way I do it is just to remember two distribution. That is the left anterior descending and the right coronary artery first. And after that, you can think about the nuance where some of the area, the wall might be supplied by either one of two coronary arteries. So if you look at the apical four-chamber view, I always try to remember that from this part here to the apical septal part, okay, is supplied by LAD, okay. And if you look at two-chamber, from here to here is supplied by LAD. Long axis from there to there is supplied by LAD. So if you can see, the shape or the pattern is relatively similar in four-chamber view, in two-chamber view, and in log axis view, which part of it is supplied by the left anterior descending artery. Okay. Now, after you remember back, just remember the nuance. For example, is in this mid-inferoseptal area of the left ventricle. This can either be supplied by the LED or RCA. In this lateral wall of the left ventricle, so basal, mid-anterolateral, and apical lateral, it can be either supplied by LAD or circumflex. Even if you could not remember that, the first step is just to remember the LAD distribution, like so and like so. Okay. Now that is the left ventricle. Now always when people look at the left ventricle, when they look at echo, they forget the right ventricular wall segment. Now why is this very important? This is important because remember that you need your right ventricle for your heart to work properly, because whatever coming out from the left ventricle have to come actually from the right ventricle. And number two, if you were particularly interested about myocardial infarction, and all of us are, the inferior myocardial infarction can involve the right ventricle wall. So you have a phenomenon called inferior myocardial infarction with right ventricular wall involvement. Okay, so let's see how to name the wall of the right ventricle. It's easier than the wall of the left ventricle because you only need to remember four segments. Okay, inferior wall, anterior wall, lateral wall, and also the septal wall. Okay, so you only need this to know these four segments. And this segment is supplied by their own coronary arteries. Okay, so two is supplied by one and two is supplied by the other one, which is the branch of right coronary artery. Now, the inferior and the septal wall of the right ventricle is usually supplied by the PDA branch or posterior descending artery branch of the RCA. Okay, so later I will show you if you have blockage at the distal RCA, you will only involve the left ventricle. If you have blockage of the mid part of the RCA proximal to the PDA branch, then you will start involving the right ventricle, which is the septal wall, and also the inferior and the lateral wall of the right ventricle. Now, if you have problem with proximal part of the RCA, proximal to the acute marginal branch, then you will have involvement of the whole of the right ventricle. Okay, so this is how you remember that. Involvement of RV wall in inferior MI means that it is at least mid, if not proximal RCA occlusion. I will show you a little bit later. So this is the picture of what a right ventricle entails. Now, number one here, we look at where is the lateral wall of the right ventricle. So it is quite easy. So whenever you see apical four-chamber view, the one at the side here, this free wall is what we call the lateral wall of the right ventricle. Okay, where else is the lateral wall of the right ventricle? Here, when you have short axis of the left ventricle at this part there, so that is the lateral wall of the right ventricle. So that is also the lateral wall of the right ventricle. So why is this lateral wall of the right ventricle is important? So it is important because this is supplied by the acute marginal branch of the right coronary artery. So we know that in myocardial infarction, if you see hypokinesia of this segment, this must be a proximal RCA occlusion, proximal to the acute marginal branch. So this is the lateral wall. What about the next one? The next one is the inferior wall. So the inferior wall of the right ventricle, the most important view is the RV inflow view here, where this is the inferior wall of the right ventricle, this one. Okay, this is the inferior wall of the right ventricle. Okay, the inferior wall of the right ventricle, importantly, is supplied by the PDA branch of the RCA, posterior descending branch of the RCA. Okay, it is also supplying the septal wall of the right ventricle here. Okay, the septal wall of the right ventricle is also supplied by the PDA branch of the RCA. Now we have gone to lateral wall and inferior wall. So lastly, let's look where we can see the anterior wall. So it is quite simple. Anything that is opposite to the inferior wall of the right ventricle is the anterior wall of the right ventricle. Okay, so that is the anterior wall of the right ventricle there. That is another anterior wall of the right ventricle from top here. Okay, so that is the anterior wall of the right ventricle. So I remind you again, the PDA branch of the RCA, if let's say you have proximal RCA occlusion, will cause involvement in the septal part of the right ventricle and also inferior part of the right ventricle. So don't forget, whenever you have you do a coronary angiogram and the patient have proximal or mid RCA, make sure you look at the septum and you look at the inferior wall of the right ventricle. Now, once you have a proximal RCA blockage, okay, usually it will involve the whole of the right ventricle, okay, because the acute marginal branch of the RCA supplied the anterior wall and also the lateral wall of the right ventricle. Now, so that I'm show you, so this is your right coronary artery here. Okay, I show you what type of wall that is involved when you have right coronary artery myocardial infarction. Now, if you have blockage at the distal part of the right coronary artery, your wall that is involved is only left ventricular wall. So you have the basal and mid-inferior of the left ventricle, and also basal and mid-infrolateral of the left ventricle. There is no right ventricle involvement. Now, let's say you go a little bit proximal, and now you have covered your PDA branch, okay? So what you have now is a combination of the initial one, so the basal, mid-infrolateral of the left ventricle, basal and mid-inferior of the left ventricle, but now you also have, in addition, the one that is supplied by PDA, which is the basal and mid-infroseptal of the right ventricle. This is the one that is shared with the left ventricle, and also the right ventricular inferior wall. Okay, so whenever you have this kind of infarction, always check right ventricle inferior wall. Now, if you have more proximal like so you will involve all of this. So this, plus all the right ventricular wall, except for a small segment called the right ventricular outflow tract segment, which is supplied by the cornus branch of right coronary artery. Okay, so I hope now you understand what do I mean by, or what do people mean by inferior myocardial infarction involving or not involving the right ventricle. So the more proximal it is, the more it will involve the right ventricle. Now I will give you two examples of coronary artery distribution. Okay, let's look at our first patient here. He is a 69 years old man with multiple comorbids. Now he was admitted for diabetic foot ulcer, developing worsening septicemia. Now in ICU, the patient developed chest pain. Now let's look at the echo image and guess what happened to the patient. Okay, so this is the first. So this is parasternal long axis view of the echocardiogram. Okay, so try to look at each of the segment and try to think which region is hypokinetic or akinetic. Now, it might be difficult to tell from this view. Okay, however, if I were just to highlight this area here, okay, so this is the basal and mid-anteroseptal. This is basal and mid-infrolateral. Now you can see that the patient have hypokinesia at this segment here, which is basal and mid-infrolateral. So this is can either be supplied by RCA or circumflex artery. Okay, so this is the first view of this patient. Okay, now let's look at the second one. So this is the apical four-chamber view. So in Mayo Clinic, the apical four-chamber view is inverted from the rest of the world. The left ventricle in a Mayo view is on the left side of the screen, the right ventricle on the right side. So just flip the other way around. I don't know why they do this. Okay, so in this situation, so it might be difficult to tell which wall that is involved right now. So this is the left ventricle, that is the right ventricle. However, what if I just highlight that area there? Okay, so I just highlight that area, all right, and I open this one. Okay, so this is an apical long axis view. So this is not the four chamber view. My mistake. So this is long axis view. So this is actually the left ventricle here. Okay, now if you look, where is the part that is hypokinetic? You can see that this part is hypokinetic. Okay, again, this is the same part as previously, basal and mid-infrolateral. Okay, the previous one is parasternal long axis. This is apical long axis, but it is exactly the same as the previous one. Okay. But let it play so that you can appreciate which part is hypokinetic. Okay, but sometimes it will be not so smooth when you look from other screen. All right, now let's look at the next one. Okay, this is the apical four-chamber view. So that is the left ventricle and that is right ventricle. So let's see if I highlight that. Okay, now I hope you can realize or you can see that this part here of the septal, so the basal infroseptal and the mid-infroseptal is actually hypokinetic, okay, compared to the rest. So I just let it play again. Okay, let it play again and one more time. Okay, and you can see that that part there is hypokinetic. And if you look at the picture here, okay, so just inverted from a normal one. So this is the mid-infroseptal, this is the basal infroseptal. So this is this one, and this is that one, and you can see that is hypokinetic. So this is the RCA territory of the coronary artery. So far, all view that we have shown you is consistent with right coronary artery involvement. Okay, let's look at the other one. Okay, so this is an apical two-chamber view. So in apical two-chamber view, before I put anything, so from here into there is LAD. Okay, from here all the way there is LAD distribution. So which part is hypokinetic? So let's say I just do that. Okay, now, okay, I hope you can tell me that the part that is hypokinetic is actually in the basal inferior and mid-inferior wall. So basal and mid-inferior wall. Okay, I hope I can convince you that. Now, if you look again at the apical two-chamber view, you can see that this is exactly the right coronary artery distribution. Okay. So now we know that this patient have hypokinesia of the right coronary artery distribution. So our question is this something to do with distal coronary artery? Is it a mid or is it proximal segment? So we already got the clue. What is our clue? Remember in our apical four-chamber view just now, we have septal involvement of apical chamber view. To be precise, we have involvement of basal infroseptal wall in the apical four-chamber view. You know that basal infroseptal and sometimes mid-infroseptal is supplied by the PDA branch of the RCA. Okay, so because that segment is hypokinetic, you know that this is at least mid-RCA involvement. Okay, so how do we want to differentiate whether this is a mid or proximal RCA involvement? We look at the next one. Okay, so this is just a short axis view. So this is a mitral level. Okay, this is what. Okay, look at that. You have a right ventricle there, so this must be septum. Okay, whenever you see the mitral valve, this must be basal. So this is basal anterior, that is basal inferior, that is basal anteroseptal, this is basal infroseptal. Right? Now, if I were to use this, I hope you realize that the region that is hypokinetic is the basal infroseptal, basal inferior, and basal anterolateral. Okay, and basal anterolateral. So again, this is the right coronary artery distribution. Okay, now look at this. Okay, this is actually the septal wall, right? So this is RCA and this is the PDA branch of the right coronary artery. So you know that there is a right-sided involvement as well. Now, how do I determine whether this is proximal or mid RCA? I look at the lateral wall of the right ventricle. I know that the lateral wall of the right ventricle is supplied by the acute marginal branch of the RCA. Now, if you look at the lateral wall of the right ventricle there, you can see that the lateral wall of the right ventricle actually contracts vigorously. Okay, so therefore you have exclude the involvement of the lateral wall of the right ventricle. Okay, so that is the lateral wall of the right ventricle there. So this one, okay, and that is the same one. Okay, so that is pretty rigorous. So what about this one? So this is very important. This is an RV inflow view. I know the view is not clear. So this is the anterior wall. This is the inferior wall. Okay, the arrow shows to inferior wall. Now, if you were to look properly, you can see that the anterior wall of the right ventricle is contracting vigorously, but the interior wall is almost akinetic. Again, this is consistent with the involvement of PDA branch of the right coronary artery. So I just highlight there. That is the anterior wall. Opposite is inferior wall. Now, if you look at this, so this is the one that is almost akinetic, the inferior wall of the right ventricle. Okay, so this is our last image. This is a short axis AOPA view. Again, it is not so clear. However, if I were to highlight that, that is the anterior wall of the right ventricle. You can see that it's contracting vigorously. Okay, so this is RV anterior wall that is contracting vigorously. Okay, that is the place that I show you just now. Okay, so what is the summary when we see this in its entirety? Number one, there is hypokinesia at the basal and mid-inferior, basal and mid-infralateral of the left ventricle, showing RCA involvement. If it's just a distal RCA, so this will be it. However, this is not distal RCA because as you can see, the basal and mid-infraseptal wall is also involved. So this septal wall is shared with the left ventricle. This is supplied by the PDA branch of the RCA. Now, once you see the septal involved, always see whether the RV inferior wall is also involved because it is supplied by the same PDA branch of the right coronary artery. And as you can see in this patient, that part is also akinetic. So in this situation, so what has happened? The patient have mid right coronary artery myocardial infarction. All the wall of the right coronary artery is affected except the RV anterior, the RV lateral, and also the RVOT wall, which is supplied by the acute marginal branch and also the cornus branch of the right coronary artery, respectively. Okay, so I hope I show you step by step how we determine which wall of the left ventricle or right ventricle that is involved. So let's look at our next patient. It is a young 29 years old man with history of heavy smoking. He has severe chest pain. What follows is his echo images. What do you think is happening? Okay, so let's look at this picture here, the next one. Okay, now, so this is an apical long axis view. Okay, apical long axis view. So look, what happened. Let's say I highlight that part. Okay, so you can see that that part is hypokinetic compared to the other part. Now, which part is that? So if you look at the apical long axis view, so that is the basal and mid-infralateral. Again, the same as our patient before, we are thinking about the right coronary artery or the circumflex artery. Now, look at our next view. So our next view is apical four-chamber view. Okay, apical four-chamber view. Now, that is the wall that is involved. So now we always remember that this is actually the basal infraseptal wall. Okay, so we know now that this is not possible to be just distal RCA. This patient also have involvement of basal infraseptal wall that is supplied by the PDA branch of the RCA. Not only that, patient seem to have some aneurysmal portion there as well. Okay, so this patient seems like having inferior myocardial infarction with subaneurysmal segment. Okay, if you look again at apical four-chamber view, you can see that this is where it is involved, the basal infroseptal. Okay, let's look at another view, and this time a color view. Okay, now you can see in apical four-chamber view there is a turbulent flow here inside that aneurysmal wall. Okay, so what is that? So this patient have also a complication of myocardial infarction, which is a ventricular septal rupture from the left ventricle into the right ventricle. Okay, this is parasternal long axis view of the same patient. Again, I hope you can see how vigorous is this LAD distribution, basal and mid anteroseptal. However, look at the place that I highlight again at the basal and mid infrolateral. You have hypokinesia. Again, that is the region supplied by the right coronary artery. Okay, let's go on next view. All right, so this is two-chamber view, a little bit slanted. So this is the aneurysm that we're talking about just now. Okay, in this view, it seems that this aneurysm have a narrow neck. Okay, remember that if you see a narrow neck aneurysm, that is usually a pseudo aneurysm. If you see a large neck, that is a true aneurysm. Now the difference between pseudo aneurysm and true aneurysm is true aneurysm, the wall of the aneurysm still consists of all layers of myocardium. In pseudoaneurysm, sometimes it can be just the pericardium or clot, and sometimes maybe part of the wall of the heart is disrupted. Okay. So this is again the apical two-chamber view, slightly slanted. So this is the left atrium, that is the left ventricle. You can see that it originates in the basal to mid inferior wall of the left ventricle, which is supplied by the RCA. So this is what seems like the pseudoaneurysm, and you can see the rupture in the wall of the interventricular septum here, where the VSR occurred. Okay, this is apical two-chamber view. Again, show you proper apical two-chamber view. If I were just to highlight that part, if you look which part is that, that is actually basal and mid inferior. So this is the RCA distribution again in multiple view that I've shown you. All right. Now, we know already that this is someone that have right coronary artery infarction. Okay. We know that this actually involves the posterior descending branch of right coronary artery. Now, our question is, does it also involve the lateral wall and the anterior wall of the right ventricle? Okay. So look at this lateral wall of the right ventricle, and I hope you can appreciate that the patient have hypokinesia of the lateral wall of the right ventricle. Okay, so in this situation, the defect in the RCA is more proximal because now it has involved the acute marginal branch of the RCA as well. So what is the summary of this patient? So this patient, again, you see from the regional wall motion abnormalities of the left ventricle that he have developed inferior myocardial infarction. We see the same involvement like in the previous patients, but additionally, we can see also the involvement of RV lateral wall. And you know that this must be a proximal RCA because this wall is supplied by the marginal branch of the right coronary artery. Therefore, the previous case is someone with mid right coronary artery involvement. This is someone with proximal right coronary artery involvement. So the patient also have a pseudoaneurysm involving the basal infroseptal wall, slightly extending to the inferior wall. We can see the communication from the left ventricle to right ventricle. So this is a ventricular septal rupture post-inferior myocardial infarction. Okay, so this is the last case. Next, looking at the coronary artery, and after this, we'll go into stress echo. So our last patient was admitted for chest pain, was found to develop ST elevation myocardial infarction. Now, the primary angioplasty was successfully done. The following are the echocardiogram of patient in coronary care unit. So this is a parasternal long axis view. Though the window is again not clear. Okay, again not clear. Now, however, I wanted to get your attention to the mid anteroseptal region there. Okay, so pay a particular attention to this part there. Okay, and you can appreciate that the part is very hypokinetic. Okay, so if you look at the picture here, so that is at the region of mid and also apical septal of the left ventricle, which is the LAD distribution. Now, if you're still not convinced, always look at multiple view. So the next view is apical long axis. Okay, apical long axis. Remember that from here up the way to there is supplied by the left anterior descending artery. Okay, so if I were to show you the region that is hypokinetic, okay, I hope you agree that that is the region that is hypokinetic, the one that I highlighted with the red dot there. Now, if you look at the region, so that is apical septal and also the apical cap, okay, apical lateral and also the apical septal of the left ventricle. Now, if you look again at the picture of the cartoon here, you can see that this is involved the apical part of the left ventricle. So that is a LAD distribution. Okay, the hypokinesia does not need to extend all the way into all regions supplied by LAD. Okay, even if it's supplied part of LAD, we can say that this is LAD coronary artery problem. Okay, let's look at the next one. This is an apical four-chamber view. Again, this is a Mayo format. Okay, so if you remember in apical four-chamber view, the LAD distribution is from here. Sorry, the LAD distribution is from here all the way to here. Okay, in bottom here, usually is RCA. Okay, now if you look at the schematic diagram, again, you can see LAD distribution. You can see that from here, okay, you can see from here to here, it is contracting, but here is hypokinetic. So this part is hypokinetic. Okay, this part is not bad. Okay, but this part is quite good. Okay, so this is again LAD distribution of the coronary artery. Okay, so this is the apical segment there that is hypokinetic. The lateral wall, this is fine. Septal wall is also fine. So again, this is the LAD distribution. Okay, look at this two-chamber view. Remember that in two-chamber view, LAD supply from here all the way to here, and you can see that the apical segment is hypokinetic. Okay, again, I play this video, right? So this is a two-chamber view. Again, your apical is hypokinetic. So what about the lateral wall of the right ventricle? So this is the lateral wall of the right ventricle that is supplied by the acute marginal wall, and this lateral wall of the right ventricle is also actually contracting vigorously. So they have nothing to do with the right coronary artery. Okay, that's the highlighted portion there. Right, so this is the AOPA view. Again, this part here is the anterior wall of the right ventricle. And again, you can see that the anterior wall of the right ventricle is contracting vigorously, and again, the right ventricle is not involved in this situation. Okay. So just last one as a bonus, I just wanted to show you just slightly proximal to the pulmonary artery here. That is the right ventricular outflow tract wall. Okay, this wall is actually supplied by the cornus branch of the right coronary artery. Okay, unless you have a blockage at the ostial of the right coronary artery, usually the right ventricular outflow tract portion is not involved. Okay, so what is the summary in this case? Now, as you can see in the patient echo, they are hypokinetic segments that are consistent with LAD distribution. You can see that the right ventricle in this situation, it is not involved, except importantly, okay, whenever you have LAD, there is one part of the right ventricle that is involved, that is the septal wall. The apical septal wall is shared by the left ventricle and right ventricle, and when you have LAD lesion, you will also affect the septal wall, so it can also affect the function of the right ventricle. Not all the walls supplied by LAD need to be hypokinetic. As long that the hypokinesia does not cross the wall supplied by another coronary artery, this is still likely to be anterior myocardial infarction. If it doesn't follow the coronary artery distribution, you need to consider other etiologies such as Takotsubo cardiomyopathy or even things like sarcoidosis. Just one important caveat, as I said, the LAD supply part of the septum and also the moderator band with also part of the right ventricle. Remember that moderator band of the RV is supplied by the part of the right ventricle. Okay, so that is our end of the coronary distribution, I hope you understand a step-by-step example that I showed you. Remember that not all hypokinesia that you see is because of coronary artery disease. Some of abnormal movement can be because of other things. For example, you can have abnormal septal motion because of pressure and volume overload. Post-cardiac surgery in patient in left bundle branch block, where you can see the septal flash and the apical rocking. You can also see regional wall motion abnormalities in patients who have pacemaker. Remember that those with myocarditis, the presentation is we are not able to differentiate 100% myocarditis and coronary artery disease. It can present exactly similar in terms of regional wall motion abnormalities, troponin rise and fall, and also left ventricular wall regional wall motion abnormalities. Now, whenever we look at the image of the left ventricular wall, we need to determine whether it is contracting normally. Is it hypokinetic? Is it akinetic? Akinetic meaning that it doesn't contract at all. Is it dyskinesis, meaning that when you contract, it goes to the opposite way, or is it aneurysmal, meaning that it is ballooning, okay? So this is the ischemic cascade. I think it is important for you to remember the ischemic cascade. Why is it important? Because you can see that the systolic dysfunction by echocardiogram precedes ECG changes, okay? So if you see someone that you suspect of coronary artery disease, if you do echocardiogram, you should see regional wall motion abnormalities. If they say this is a case of non-STEMI or ST elevation myocardial infarction, because it happens very early. Now we go into stress echocardiogram. I just wanted to explain to you that there are different modality of stress echocardiogram. So we can do upright exercise. So this is what we do, I think, generally in Malaysia. Now in Mayo, they also do a lot of supine bicycle exercise. So the reason they do supine bicycle exercise is that it is easier to image because you can image without asking the patient to move. The other one that we do is dobutamine and also vasodilator, which is quite rare. So what is the difference between all these three? So in general, if the patient can't exercise, we try to exercise the patient. Why is exercise very important? That's because the amount of exercise that you do is directly related to the prognosis, independent of whatever that is present in your coronary artery. So if you compare two patients, similar age, those that can do more exercise usually will survive better than those that do less exercise. In terms of the difference between upright exercise and supine exercise, in upright exercise, you have higher heart rate increase, whereas in supine bicycle exercise, you have higher blood pressure increase. As you know, we look at the combination of heart rate and blood pressure. So when you look at the combination, the effect is quite the same. Now, when do we use dobutamine stress echo? So we use dobutamine stress echo when the patient, number one, is unable to exercise. So let's say you want to look for ischemia. Which of the modality that you wanted to choose? Now, if you want to look ischemia, you can either use exercise or dobutamine. However, if your patient is able to exercise, it is much better to do exercise echocardiogram. Okay. However, if you want to look at viability, what do I mean by viability? When you said that you wanted to look at viability, you mean that you want to look at a segment that is already affected, that is that a segment that is already hypokinetic or akinetic, and you wanted to know whether this segment is viable or not, then you use dobutamine. We don't recommend using exercise echocardiogram for that situation. So I repeat, to look for ischemia, you can either use exercise or dobutamine, but for viability, looking at the region that is already affected, you use dobutamine stress echocardiogram. Remember that at high dose, dobutamine stress echocardiogram reduce systemic valvular resistance. So this is the grading of wall motion. Okay, so score is 1 to 5. Okay, score 1 is normokinetic, 2 is hypokinetic, 3 is akinetic, 4 is dyskinetic, and 5 is aneurysmal. So sometimes what they do in echo is they want you to recognize this thing called wall motion score index. So what is wall motion score index? So I explained you previously, okay, you can see all the left ventricle wall in this three picture here. So in the basal, mid, in the basal, mid, and apical of short axis view, you can see all the ventricle there. The same go to apical 4, apical 3, and apical 2. So what happened is that you grade each of the wall. So there is 16 wall here. So whichever that you can grade, you grade from 1 to 5. Remember that 1 is normal, 5 is aneurysmal. So you grade at the beginning, and also you grade at the end when you do the stress. Okay, and then you do the stress as the numerator and the rest as the denominator. Okay, usually it should be 1. Okay, if the beginning is all normal, so it's all 1. At stress, it is all 1. So you divide the stress and rest, it should be also 1. Okay, however, if let's say you have worsening, okay, for example, at rest, you have a certain segment that is 1. At rest, a certain segment that is 2 or 3, for example. Now, if you divide the score of all this, average of all this, with the beginning, you will have something that is more than 1. Okay, so like this example that were given here, when they start, the wall motion score index is 2. So there is a combination of hypokinesia and akinesia. However, when they stress the patient, there is a region that become hypo from normal or become akinesis from hypokinetic. So when we start with a wall motion score index of 2. We stress, we have wall motion score index of 2.38. So you know that somewhere along the line, there is worsening in wall motion abnormalities. So what does worsening in wall motion abnormalities means? That means ischemia until proven otherwise. Okay. Whenever you do whether stress echo or dobutamine stress echo, if you start with normal and become hypo, or you start with hypo and become more hypo, that always means ischemia. Whenever you see a worsening of something, then that is ischemia, meaning that your coronary artery, there is critical blockage that you might need to do coronary angiogram and open it. So how do we do our dobutamine stress echocardiogram? If we do for low gradient cerebral stenosis, we use low dose dobutamine. So what do I mean by dose? It is 5, 10, 15, and 20. If you use for viability or for stress, you lose until high dose, meaning that until 40 microgram per kilogram per minute. Okay, so how do you do this in dobutamine? We do a 3-minute stage. Okay, so we start at low dose, 5 microgram per kg per minute. Every 3 minutes, we increase 5. So from 5 to 10, 10 to 15, 15 to 20, so on and so forth. And when do we stop? We stop when the patient becomes symptomatic, or when the patient have achieved 85% of their maximal age predicted heart rate, which is 222 minus their age. Okay. So what is our goal? We wanted to diagnose hemodynamically significant coronary artery stenosis. Usually, if coronary artery is blocked 50% or more, if you stress the heart, you can see hypokinesia of that segment. Okay, so if you don't remember anything from my talk, the reason, like one of the most important reason, is to detect ischemia, wall that is at risk of ischemia. Okay, so normally if it's more than 50% blockage, if you stress them, the wall will become hypokinetic. If the wall already started hypokinetic, it become more hypo or it become akinetic. Remember that even one segment is enough to diagnose. Okay, obviously the more segment that is involved, the more specific your diagnosis. The less segment, the less specific but more sensitive to rule out ischemia. Okay, what are additional features to this suspicion? If at rest you do echo, and then after that at stress the LV dilated, that is suspicion. Okay, that is an indication of coronary artery disease. Your LV should augment at least 5% when exercise. So any failure to augment ejection fraction by 5% is also something that we worried about. So when do we stop? Obviously, if the ECG show ST elevation. So in general, when you do stress echocardiogram or dobutamine stress echocardiogram, the ECG is not reliable. Okay, unless when you see ST elevation or malignant arrhythmia such as ventricular tachycardia. Okay, even if you have a decrease in blood pressure, you also have to stop your exercise stress echocardiogram. All right. So we need to move sometimes beyond sensitivity and specificity. So we need to decide a priori what is the patient risk of developing ischemia or having coronary artery disease. A patient with low risk of coronary artery disease, you don't need to do any testing. because a testing, even is positive, might be a false positive. Those that have very high likelihood of coronary artery disease, you might skip and do straight go for coronary angiogram. The best use for stress echo is someone with medium risk of coronary artery disease. Now, what is the sensitivity and specificity for stress echo overall? So in a trained eye, the sensitivity is 75 to 85%, and the specificity is 80 to 90%. It is comparable in men and women, but more importantly, you have to try your best to get the heart rate more than 85% of age predicted maximum heart rate. Okay. Now, this is one of the most important slide for you to understand. Okay. So remember, I told you the reason we do stress echo. The reason we do stress echo, be it lobotomy or exercise, number one is to look for ischemia. What do I mean by ischemia? Ischemia is at a region that is at risk of developing myocardial infarction or at risk of developing myocardial infarction. Just give me a moment. Okay. So let's say you have a patient that come to your clinic, okay, and say that he developed chest pain when he do exercise. So you want to see whether he have blockage or stenosis of the coronary artery. Okay. So number one. Now, if you have acute ischemia, of course, you will have regional wall motion abnormalities. Okay, so the region we do exercise stress echo or lobotomy stress echo, if you have a normal regional wall motion abnormalities at rest, let's say we do exercise stress echo, we want to induce that ischemia, so that if you start with stress and then you start with normal wall motion, and when you exercise and when you give lobotomy, it become hypo, that means you have induced ischemia in the patient. Okay. The other one is you start with hypokinesia, but then it become more hypo akinetic, meaning that you have determined that the patient have ischemia. Okay, that is number one, to look for ischemia. Okay, now what about viability? So in viability, we see and look at someone that already have a hypokinesia or akinetic. Now we wanted to see whether their segment is viable or not viable. So how can we know whether something is viable or not viable? We do lobotomy stress echocardiogram. Okay, so for example, someone have hypokinesia of left anterior descending artery. Number one is we wanted to know why this patient have hypokinesia of that segment. So why is the reason we have hypokinesia? So the reason is basically three. So number one, okay, this is chronic hypokinesia of the left ventricle. Okay, number one, let's say you have an acute ischemia in the past period. However, you don't have any revascularization or you revascularize late. Okay, so number one, this can become chronic ischemia and the patient can hibernate their left ventricular wall. So one of the differential diagnosis of hypo or chronic hypokinesia is hibernating myocardium. So that is one of the differential diagnoses, hibernating myocardium. The second one, of course, if you don't revascularize or you revascularize rate, that segment will become infarcted. There is another region of hypokinesia, the reason for hypokinesia. One is hibernating, someone with chronic ischemia. Another one is infarcted. What is the last one? Say you have an acute ischemia and then you able to revascularize, be it from primary PCI or thrombolysis. However, when you do echocardiogram, it has not have enough time for the patient to recover their function. So that is stun. Okay. If you see, all this will start with hypokinesia. So if you see all these patients with hibernating myocardium or infarcted myocardium or stunned myocardium, their left ventricular wall at rest will be hypokinetic. Okay. So you give lobotomy, is you wanted to know which is which. Is this patient hibernating? Is this infarcted or is this stunned? So you give them lobotomy. So there is few different response that you can expect. If let's say the patient have hibernating left ventricular wall, if you give lobotomy stress echo, okay, so we start with the patient with infarcted first. Okay, if let's say the patient have infarcted myocardium, if you give lobotomy stress echo, one of the way it changes is there is no change. Okay, there is no change. It starts with hypokinesia. You give dobutamine, it is also hypokinetic, it is no change. That means that that region that you are looking at that is hypokinetic is already infarcted. Okay, it's already infarcted. Okay, that region is infarcted. There is no need for you to do anything. Okay, however, if you start with hypokinetic, however, when you give dobutamine, the hypokinetic become worse or the hypokinetic become akinetic. So what is this? So this means the wall that you're looking for, that you're looking at, consists of infarcted segment. However, at that peri-infarct area, there is a region that is also susceptible for ischemia. Okay. Now, in this situation, you need to revascularize because you not revascularize, you might make the hypokinesia worse. Okay, so there is two situations. Either what you're looking for is just an infarcted wall in which the surrounding area is normal. Therefore, when you do dobutamine, there is no change. Or you're looking at the infarcted wall, but the surrounding wall is also at risk of having ischemia. So in that situation, there is a role for revascularization because you don't want it to get worse. That is one. The other way that you can have response is if you have hibernating wall. What do I mean by the hibernating wall? There is no infarction, so the wall is still alive. Now, the reason you have hypokinesia is because they want to preserve the energy. So therefore, it reduces its function. Now, in this situation, when you do dobutamine stress echo, you will see a biphasic response. What do we mean by a biphasic response? When we give low dose dobutamine, normally 5 mic per kg per minute, you have an improvement in function. And when you go high dose, usually 5 to 8 and more, then the function will get worse. So low dose, it become better. High dose, it become worse. That is a hibernating myocardium. So what does hibernating myocardium mean? There is a blockage. There is no infarction. The wall is actually preserving the energy. Now, this one is the best in terms of predicting revascularization. Because once you revascularization this one, the probability that this will become normal is very, very high. Okay, so 3 reasons why you have chronic hypokinesia and you want to do dobutamine for viability. Number 1, you want to either your patient is hibernating. In this case, if you do dobutamine, you will have biphasic response. Number 2, your patient is infarcted. If they are just infarcted with a normal surrounding wall, the hypo will continue to be hypo. If they are infarcted and in addition they have peri-infarct ischemia, they will become more hypo when we give dobutamine. All right. And lastly, the heart is just stunned. The coronary artery is normal, okay, but the left ventricle have not time to recover yet. In this situation, if you give dobutamine, low dose, it will improve, the contraction will become better, and high dose, it will continue to become better. So that is stunned. So that is 3 different response to dobutamine. Of course, that is if you start with hypokinesia. If you start with normal, whenever it becomes hypokinetic, that means that you're having some wall that is at risk of ischemia. Right? So I just wanted to show you again because I think this is very important for you to understand in terms of these boxes here. Okay. Now, if you start with a normal wall motion and you finish with hyperkinetic, meaning that it contracts more vigorously, just we expected. Let's say this is the wall that you are looking for. The wall consists of a normal wall. Okay, there is no risk of ischemia, so you don't need to do anything. Now, you start with normal wall motion. However, when you give stress or dobutamine, it becomes hypokinetic. If let's say this is the wall that you're looking for, the wall have a region that is at risk of ischemia. Okay, there is a region that is at risk of ischemia, you might need to revascularization. So this is ischemia. What about if you have hypokinetic segment to begin with? And then you end up with hypokinesia as well. So it's the same. So if you look at the wall that you're looking at, you know that part of the wall is infarcted, but the rest are normal. Therefore, you start with hypo, you end also with hypo. So this is no need to do anything, okay? This segment is non-viable, you don't need to do anything. Now, if you start with hypokinetic, and then it improve, and then it become worse. So biphasic, low dose dobutamine, it improve, high dose dobutamine, it worsen. What that means is that you're looking at the region of the wall that is hibernating. Okay, so this region is not dead. It just reduces its function in the presence of chronic ischemia. So this is the one that is best in terms of predicting response to revascularization. What is your hypokinetic and akinetic? It improves and is continue to improve, meaning that what you are looking at is a stunned myocardium. You don't need to do anything. This is just a function of time. So when you wait, it will improve by itself. What if you start with hypokinetic and then it becomes worse? What does that mean? That means you have an infarcted segment. So what you're looking for is infarcted segment. So it's the same as that. So what is the difference? The difference is in here, you can see the yellow thing that is surrounding it. This is also at risk of ischemia now. You have a peri-infarct ischemia. Okay. So this is someone that have ischemia. So this might benefit from revascularization. So few person or few scenario that benefit from revascularization. Ischemia, normal to hypo, hibernating, hypo, improvement, and then worse again by phasic, or this one, infarcted with surrounding ischemia. You start with hypokinesia and then it worsen. Okay, so this is a patient that also can benefit from revascularization. Okay, so let me give you some example. So I want to apologize beforehand because the picture might not be so clear, but I will try to make it clear for you. So let's look at our first case. This is a 62 years old man with diabetes and chest pain on excision. Okay, so the patient undergo stress echocardiogram. Okay, I've already annotate the picture. So this is the apical four-chamber view. So that is rest. The regional wall motion is normal. That is pre-peak and that is peak. Okay, this is exercise stress echocardiogram. Rest, pre-peak, and peak. Rest, pre-peak, and peak. Okay, look at that. Okay, now look at next one. So this is parasternal long axis view. Rest, pre-peak, and the bottom one is peak. Okay, so that is three picture: rest, pre-peak, and peak. Okay, this is short axis view: rest, pre-peak, and peak. Okay, I just play one more time: rest, pre-peak, and peak. Okay, short axis view: rest. Okay, so I hope you can see that one. Okay, so just I show you again the apical four chamber view. So let's see whether you can tell. Okay, all right. So just bear with me for a moment. I think the PowerPoint has stopped. Okay, just give me about 1 minute just to restart it. Usually it will be okay once we restart it. Restart the PowerPoint. Just give me 1 moment. Because sometimes when you play the video for quite a while. Okay, so I got it back. Okay. So I hope you can see now. Let me share the screen. Share screen. Share. Okay, I hope you can see now the image. Okay, so this is rest, pre-peak, and peak. Okay, right. So let's go next one: rest, pre-peak, and peak. Okay, so now if you want to see looking at the stress echocardiogram, so what is your diagnosis? So looking at the exercise stress echocardiogram, what is the diagnosis? Is this hibernating LAD segment? Is this ischemia right coronary artery? Is this ischemic LAD segment? Or is that multi-vessel ischemia? Okay, so you can all answer in your own mind. Okay, so this is actually someone with multi-vessel ischemia. All right, so when we do stress echocardiogram, if we start with a normal regional wall motion, if it's become hypokinetic on exercise, then it is ischemia. In our stress echo that I showed you before, at the beginning, there is no regional wall motion abnormality. But at exercise, you can see that there is hypokinesia at LAD, right coronary artery, and circumflex territory. Okay, so I just show you the box. Okay, you just look at the box there. So that is the LAD segment. Look at what happened at peak. Okay, so you can see that the LAD segment start normal, and you can see that at peak it become hypokinetic. Okay, what about the right coronary artery segment? That is the RCA segment. Just look at the difference at rest at pre-peak. You can see that it start with a normal contractility. However, at pre-peak, you can see that there is obvious hypokinesia at LAD and RCA segment. So this is ischemia. Okay, let's look at the next one. So this is the long axis view. I just box that. That's the LAD segment. Now you can see obviously at rest, the LAD segment is contracted vigorously. Look at what happened in LAD segment at pre-peak. You can see that it has become hypokinetic. Okay, what about the RCA segment during starting? Okay, this is exercise straight echo. It is normal, but when we do exercise, it becomes hypokinetic. So I hope you can see that. So that is the LAD segment that is hypokinetic. That is RCA segment that is hypokinetic. Okay, so this is multivessel ischemia. Okay, I hope you see that clearly. Let's look at the next patient. So this is a 43 years old smoker with atypical chest pain. So this patient undergone exercise stress echocardiogram. So this is the patient exercise stress echocardiogram. Okay, so this is a short axis view. All right, so this is the mid segment of short axis view. So that is septal wall, anterior wall, and inferior wall. So anteroseptal, anterolateral, infroseptal, and infrolateral. So anterior and inferior. Look at rest, pre-peak, and peak. Look at rest, pre-peak, and peak. Right now, this is parasternal long axis view. Rest, pre-peak, and peak. Rest, pre-peak, and peak. Okay, just go one more time. Rest, pre-peak, and peak. Okay, let's see. What is your diagnosis for the stress echocardiogram? Is this RCA ischemia? Is this LAD ischemia? Is this stunned left anterior descending artery? Or is this hibernating right coronary artery? Okay, again, answer in your own mind for stress echocardiogram. So whenever we do stress echo, usually we are looking for ischemia. Okay, so this is patient with LAD ischemia. Okay, so this patient begin the test by having a normal regional wall motion. So obviously this is not a viability testing, because viability we start with hypokinesia or akinesia. So this cannot be hibernating or stunning. However, there is normal motion of LAD territory at rest that worsen on exercise. This is an example of LAD ischemia. Okay, if I were just to show you, all right, and you look at the different inside the box of LAD segment of short axis papillary muscle view, this is a big segment. So look at the anterior wall, which is contracted normally. If you look at this part of the anterior wall, it has become hypokinetic. Okay, start with normal and become hypokinetic. Okay, this is ischemia. What about this parasternal long axis view? Look at inside the box, inside the circle here. Look at especially at the mid segment of the septum. So look at the mid segment of the septum. You can see that it starts with a normal regional wall motion abnormalities. You can see there's hypokinesia, especially at this segment there. Okay, so start with normal and progress to become hypo. So this is again an example of someone with ischemia. Okay. Let's look at our next case. So this is a 56 years old man with history of chest pain. Okay, when you look at the resting echocardiogram, you see that there is hypokinesia in the LAD and right coronary artery segment. Okay, so what you want to do now is you are doing dobutamine stress echo to look for the viability of the hypokinetic segment, or if there is any additional ischemia. All right. So this is the echocardiogram. This is rest, no dopamine. This is low dose dopamine. This is high dose dopamine. Rest, low dose dopamine, high dose dopamine. Rest, low dose dopamine, high dose dopamine. So let it play again. Remember that the patient start with hypokinesia at the LAD and RCA segment. Okay. All right. So look at that. Okay. One more time. All right. So looking at the dobutamine stress echo, just that picture, what is your diagnosis? Is this ischemia of the LAD? Is this hibernating LAD and RCA? Is this stun LAD? Is this infarcted LAD? Which one is it? Ischemia LAD, hibernating LAD and RCA, stun LAD, and infarcted LAD. So which one is this? Right? So this is hibernating LAD and right coronary artery. What does hibernating mean? It means that there is a blockage, but the wall is still alive. The wall actually has reduced its function to cope with that stenosis. So this is the one that respond very well to revascularization. Now, I just wanted to stress few important things on stress echocardiogram. If you are doing exercise stress echocardiogram, mostly you are looking for ischemia, namely worsening in regional wall motion. If you are doing dobutamine stress echo, you can still look at ischemia. However, the more important utility is to look for response of a region with existing regional wall motion abnormalities. If you start with hypo and become worse with dobutamine, meaning that you have infarction with ischemia, with peri-infarct ischemia. If you start with hypo, there is no change, so that is an infarcted segment with normal surrounding myocardium. If you start with hypo, it better at low dose and high dose, meaning that this is stunned myocardium. Start with hypo, biphasic, better at low dose and get worse at high dose. This is hibernating. And this is exactly the one that we can see in this case that I show you. Okay. Same the case that I showed you before. If I were to just show you the LAD segment, okay, just look at the changes between rest, low dose, and high dose. So at rest, it is hypokinetic. At low dose, it becomes hyperkinetic, so it becomes better, the contractility. However, at high dose, you can see it becomes hypokinetic again. Let's look at the inferior wall. At low dose, it is at rest, it is hypokinetic. At low dose, it becomes hyperkinetic, meaning that it becomes better. At high dose, it becomes hypo. So you can see a biphasic response. So this is a hibernating LAD and also right coronary artery segment. So this will respond very well to revascularization. So let's look at this patient. We have a 77 years old man with severe bilateral knee osteoarthritis. He have occasional chest pain. As he is unable to exercise, he undergo dobutamine stress echocardiogram. Okay, so this is parasterral long axis view. That is rest, low dose, and high dose. Okay, just look at rest, low dose, and high dose. Okay, see whether there's any segment that start with hypokinesia and see whether there's any change. Okay, rest, low dose, and high dose. Let's go to the next one. So that is rest, low dose, and high dose. Okay, think yourself in your mind, rest, low dose, and high dose there. All right. So looking at the short axis of DSE above, what is your diagnosis? Is this ischemia of the LAD? Is this hibernating right coronary artery? Is this stunned left atrial descending artery? Or is this infarcted left anterior descending artery? Okay. So the answer for this one is hibernating right coronary artery. Right. So this patient, if you look at it, okay, so this patient start with regional wall motion abnormalities. So it is better at low dose and again worse again at high dose. So this patient have hibernating right coronary artery. So this means that there is stenosis of the vessel. So the area is at risk. There is no infarction and revascularization will correct the regional wall motion abnormalities. Okay, so this is the one that I've already explained before. So just to show you again, if I were to highlight the vessel infralateral wall there, at low dose and high dose, I hope you can see clearly that it gets better and then it gets worse. It gets better at low dose and then it will become worse back at high dose. So this is a hibernating myocardium. So better at low dose, higher at worse at high dose. Okay, let's look at apical 4. Okay, I highlight that it become better at low dose and it become worse again at high dose. Okay, better at low dose and worse again at high dose. So this is hibernating right coronary artery. right? So this is our last case for today. So the patient below is a 66 years old man with a history of inferior myocardial infarction a week prior that was successfully thrombolized. His resting echocardiogram show RCA hypokinesia. So we do a dobutamine stress echo to assess the viability of that segment. So this is the echo, all right? So rest, low dose, high dose, rest, low dose, high dose. Okay, the patient start with inferior wall motion abnormality, hypokinesia. Okay, that is low dose and that is high dose. Rest, low dose, high dose. All right. So what is the most likely diagnosis for the stress echo? Is it RCA ischemia, infarcted RCA, hibernating RCA, or stunned RCA? So I'm sure by now you already know that this is actually a stunned RCA. So you can see that looking at the regional wall motion abnormalities of the right coronary artery segment, it starts with hypokinesia. When you give 5, it continues to get better. Okay, and when we give 13, it becomes even more better. Okay, so this is a monophasic response. It becomes better all the way. So this is a stunned myocardium. You remember the patient has already been thrombolized, meaning that the ventricle is still stunned. You just wait, and hopefully the left ventricle will recover by itself. Okay. So this is a factors that affect the accuracy of stress echocardiogram. So you can have false positive because of cardiomyopathy, paroxysmal septal motion, or even microvascular disease. Remember, a positive stress echo, a positive dobutamine stress echo give worse prognosis, regardless whether you have epicardial coronary artery stenosis or not. Okay, so let's say you do a dobutamine stress echo that you interpreted as positive, and then suddenly the interventionist do coronary angiogram and say that, hey, how come you say that there is ischemia, but when I do coronary angiogram, there is no blockage? Doesn't matter, okay, because the prognosis is poor either way. So when you do dobutamine stress echo, even if the coronary artery does not show any blockage, a positive stress echo confer a bad prognosis. So before I finish, I just wanted to show you, I think this is my last slide. This is just a repetitive, but I think this is very important for you to understand in terms of stress echocardiogram. Okay, if you start with a normal wall motion and become better, so that is normal, you expect that. If you start with normal and become hypokinetic, the region that you're looking at and become hypokinetic actually have a region that is at risk of ischemia. You need to do coronary angiogram in this patient. If you start with hypokinetic and you end also with hypokinetic, so that means the region that you're looking at has infarcted segment. Okay, it's already dead. The surrounding area is normal, so there is no need for you to do anything. If you start with hypokinesia and then it gets better and then it becomes worse back. Okay, this is the most important one. So this is hibernating. So you have area that have reduced its function in the presence of chronic ischemia. This is the best one in terms of reverse transition. If you start with hypokinesia, you go for improvement and then also improvement, meaning that it's a sustained improvement. This is a stunned myocardium. You don't need to do anything. This is a function of time. It will improve by itself. If we start with hypokinesia and it has become worsened, so that means that you have an infarcted segment, yes. So it's the same as this one, but the only difference is you also have surrounding peri-infarct ischemia. So you need to revascularize this one. If you don't revascularization, the hypokinesia will get worse. So I think that is the end of my talk today. So I hope that you can understand dobutamine stress echo or stress echocardiogram today. So if you have any question, you can ask me in the question and answer segment. So right, let's see if there's any question.